A very good morning to all. Welcome to Nuances of Phaco Training, an instruction course on how to impart a good training to our residents and fellows. We all accept it is essential that all residents and fellows should know how to do a proper SICS and a phaco emulsification, at least in uncomplicated cases. But the reality is very different. Here we aim to demonstrate how a good phaco training can be given even in private hospitals. The first topic today is on developing hand-eye coordination. It will be dealt by Dr. Nilufar Syed Mohammed. Dr. Nilufar is a consultant eye surgeon from iVision Eye Hospitals, Thrissur. Over to Nilufar.
Good morning everyone. My topic is developing hand-eye coordination in cataract surgery. As you all know that cataract surgery has a steep learning curve with high stakes for the patient. Yes, as I said, cataract surgery has a steep learning curve with high stakes for the patient. Hands-on experience is necessary to improve the surgical performance and prevent complications. Studies have proven that wet lab training shortens the learning curve and reduce adverse events in practice. Now, the wet lab training, it provides a risk-free environment where the surgical trainees become familiar with the handling of surgical instruments, microscope, develop good hand-eye coordination, and practice the surgical steps. Ideally, a wet lab should simulate an ophthalmic operating room. It should include a operating microscope, ophthalmic surgical instruments, refurbished or re-sterilized single-use instruments, animal or human cadaver eyes, and devices to mount them, phaco machine refurbished. Now, before the trainee starts the wet lab training, they have to attend lectures on the surgical anatomy of the eye, watch detailed videos of steps of surgery, also of its complication and management, attend live surgeries and observe the surgeon performing surgeries. In wet lab, they should familiarize themselves with the instruments, including the microscope and the foot pedal. Now, initially, we start off with suturing. It is a great way to develop hand-eye coordination. What we use is polyurethane foam sheets which come with the ophthalmic suture packaging, and the trainees are asked to place at least 20 sets of sutures each session, and we note the time and the placement and all. This is what we do. We place the polyurethane foam sheets, we fix it with rubber band on a betadine bottle, and we draw with the shape of cornea and perpendicular so that perpendicular sutures can be placed. And the trainee, after placing the sutures, they have to come and show the mentor or trainer. We check for the equidistance and whether sutures are tight or loose, and also the time taken. Now, coming to practicing the steps of surgery, human cadaver eyes provide the best model for teaching ocular surgery, but it's difficult to get unless it's not suitable for transplantation. Meanwhile, goat eyes are easily available, and its anatomy and tissue texture closely resembles that of the human. What we do is we place the goat's eye, we mount it on we mount the globe on a forceps jar and take 2 bites with 3-0, and then secure it in place with rubber bands, and we inject normal saline to make it firm. Other conventional mounting devices are available: Mandel's mount and styrofoam wig head. The trainee can start practicing creating sklenocorneal tunnels on 4 sides of the globe. At least 20 tunnels should be made on goat's side. You can practice capsulorhexis and hydrodissection to a certain extent, but there is limited scope for practicing nucleus prolapse and delivery. Here our trainee, she is practicing tunneling on goat's side in our wet lab. Moving on to capsulorhexis, we can use thin polythene film that comes with the packaging of IOL. We mark circles of 6 to 7 millimeters, and the trainee uses a cystitome to practice rhexis within the mark under the microscope. At least 100 attempts of capsulorhexis should be done like this. Alternatively, you can use gift wrapping paper to practice rhexis. Here she is using polythene film that comes with the packaging of IOL, and this is the gift wrapping paper I mentioned. This is much better, I feel, because you need more control of it, and they have to place, they have to do the rhexis within the markings. And minimum 100 capsulorhexis should be done like this and shown to the trainer. Now moving on to the phaco emulsification. Nucleus extracted through SICS is placed in the model eye, and by using phaco machine in the wet lab, surgeons learn the principles of phaco while practicing using the use of foot pedal. What we do is the SICS that we extract, the nucleus that we extract through SICS, we place it in the model eye, and then the trainee practices in the wet lab the various steps of phaco. Coming to synthetic and artificial eye models, these are commercial ones. Teaching of cataract surgery around the globe varies according to the resources, financial power, and demands of each location. Its cost is relatively high compared to the eyes of animals. Just mentioning a few, there is something by Simul Eye, that is Simulorhexis, where you can practice the capsulorhexis, and then more popular ones are Bionica models, where you can practice several steps. And then the complete wet lab kit of Kitaro. It is a complete commercial kit in which instruments are also coming. Moving on to the modern training techniques in cataract surgery. As you all must have heard, virtual reality based simulation training is gaining popularity. It's part of the curriculum of ophthalmic residency programs in many Western countries. You can develop microsurgical motor skills and good hand-eye coordination. We can use instruments and get good tactile feedback also. You can practice nearly all the steps of cataract surgery, and studies have shown that it reduces the surgical time and complication rates. IC, this is the most popular VR simulator training program that's available, and it is almost standardized in Western countries, and it's part of the ophthalmic residency training programs in US. It's used in high income countries. You can practice all the steps of cataract surgery, and also VR surgeries can be trained using this. Its software is also capable of storing residents' performance metrics, allowing a score to be generated as well as a feedback. We can watch a video.
IC Surgical is a high-end virtual reality simulator for intraocular surgery training. Original instrument handpieces are inserted into the simulator's model eye. Looking through an OR microscope, trainees experience their interaction with tissue and intraocular structures simulated in real time. The pre-installed IC courseware offers training at different levels of difficulty, from basic skills training through to surgical procedures and complications management. For cataract surgery training, instruments such as forceps, viscocannula, cystotome, and phaco probe are available. The simulator provides an OR machine interface and instrument foot pedal to control fluidics.
Moving on to the next VR simulating machine. You all must have heard about Help Me See. It is available in India. They have training programs in SICS and phaco emulsification. This is also VR based, and you need a trainer to train you in this. It is slightly different from the IC. Moving on to live surgical training. Initially, the trainee has to undergo an observation period where they closely observe the senior surgeons operating on patients and maintain aseptic precautions. Patient selection is important for the trainees. You need to choose uncomplicated cases. The microscope should have an observer scope and or camera and monitor for viewing. Initially, you start with step surgeries and progress to the next step only after performing the previous steps satisfactorily. Patient safety is very important. So if there is any difficulty, it's immediately taken over by the trainer. We have to, as the surgery is recorded, you can discuss later on with the mentor and trainer. You have to maintain a logbook. And also there is a scoring, the objective scoring of the surgery, which can be adopted. It is using the ICO Oscar. It is available in American Eye Academy website and ICO website. Here the steps of the surgeries are divided into 13 steps and then scored according to novice, beginner, advanced beginner and competent surgeon. So this is very good in evaluating and assessing the progression of the trainee. Post-op complications should be discussed with your trainer, and follow-up of all the cases should be done. Thank you.
Thank you, Nilufer. That was a very useful talk with good visuals. She has highlighted a very important step in the training. We normally look at our hands whenever we do a fine activity, but in microsurgery, you have to look through the microscope and not on our hands. This needs some training and practice, and above all those videos, what all things we are doing in our hospital, Dr. Nilufar had shown. So all these things will help the trainee to get their hand-eye coordination. Thank you, Nilufar. That was. Next, I would like to invite Dr. Preeti Prashant to speak in SICS step surgery. Dr. Preeti, we all know her very well. She's a prolific SICS surgeon from Shornur.
Thank you. Good morning all. First of all, let me thank KSOS and Dr. Jyoti Anu for giving me this opportunity to be part of this instruction course. My topic for the day is steps of small incision cataract surgery. Okay. Like any other surgery, having a good anesthesia is important, and beginners can either choose retrobulbar, peribulbar or PST silocaine, to which hynidase is added. Topical only if you are very confident. After you infranasal area is selected, I prefer giving PST because it is under our control and we don't have to depend on the blowchrome sisters. A small nick is made with conjunctival scissors and a little dissection is done in the tenons, and around 3 ml of silocaine is injected. And after massaging well, we can go on to the conjunctival peritomy. You can do even rectus, superior rectus or lateral rectus can be taken, especially for beginners, to keep the eyeball central and fixed, and it also helps in nucleus delivery with the assistant holding it and slowly releasing it after the nucleus is engaged in tunnel. You can do a conjunctival peritomy either at superior or lateral area. Temporal tunnel is definitely better because it helps to obliterate the against the rule astigmatism, which is very common in elderly, and also helps to expose the eye even in deep set eyes for better tunneling and better nucleus delivery and ease of surgery. So a temporal tunnel can be chosen. Then going on to the shape of tunnel, frown is preferred with a length of around 6 to 7 millimeter outside according to the size of nucleus. Inner aspect will be a little bit more lengthier, and width will be around 4 millimeter, 2 millimeter in sclera and 2 millimeter in cornea to get self-sealing effect. Depth should be around 0.2 to 0.3 millimeter. Tunneling is triplanar. After the globe is fixed with the fixation forceps, you can use either blade breaker to do the grooving, or you can use the crescent knife itself for better control over the first grooving. Then you can tunnel through the stromal fibers with wiggling motion. You can start at one end and continue till the other end so that a single plane is attained. Care should be taken that you are not too superficial so that buttonholing is done, and you are not too deep so that there is more bleeding from the root of iris and chances of premature entry is there. And once the two planes are made, then you go and prepare for the rhexis by doing a paracentesis can be done with keratome. Here I have done already the paracentesis and air bubble is injected, and under the air bubble the staining of the anterior capsule can be done with around 0.1 ml of trypan blue. Now the entry with keratome is done, corneal entry. We can use the bevel up keratome. A small dimple is made, and entry is done with the keratome. Then the cystitome, which is a 26 gauge needle with a 90-degree tip and 120 degree away from the tip is used. You have to make a deep anterior chamber with injecting a good amount of viscoelastics. Care should be taken that you don't over inject and overfill the anterior chamber so that iris can prolapse. Then while making the flap, take care to see that the flap is always flat on the anterior surface of the lens, and start by doing around 6 mm diameter capsular rhexis. You can make it smaller or bigger depending on the size of the nucleus. Once the rhexis is complete, again the cystitome is taken out exactly in the sideways so that you don't damage the endothelium. Next step is the tunnel is extended with the keratome on either side of the initial entry. Take care to cut the inner aspect while you enter the anterior chamber and not while coming out. In between each step, take care to fill the anterior chamber with enough viscoelastics. When you are doing small incision cataract surgery, you should not bother too much about the length of the tunnel, and you should not be much bothered about some bleeding. Next is hydrodissection and prolapse of nucleus. Do hydrodissection at multiple sites all around, then tap the center to not increase pressure in the capsular bag. And once hydrodissection is complete, a ring will be seen around the nucleus in most of the cases, and you can do a minimal hydrodelineation between the epinucleus and endonucleus so that the pole of the nucleus will prolapse. This is doing hydrodissection and slightly tapping in the middle, and you can see the pole of the nucleus prolapsing. Then again you inject viscoelastics mainly above the nucleus so that to protect the endothelium, and also underneath to deepen the capsular bag. Then the nucleus management. Viscoaspiration only for soft nucleus. I prefer using irrigating vectors, which is safest. You can introduce the irrigating vectors through the main tunnel and up to the following the curve of the nucleus up to the inferior aspect of iris. And while withdrawing, take care to see that you don't catch the iris at any point. And once the nucleus is engaged in tunnel, you can inject saline so that it uses, you have to depress the scleral lip as well as inject saline. So it mechanical as well as hydrostatic pressure is used. And once you have a rectus suture, your assistant can slowly release it after it has been engaged in the tunnel. While you are withdrawing, the sister can slowly release the rectus suture. This is all for beginners. Then cortical aspiration is done with irrigation aspiration 22 gauge cannula. Make sure to do some vacuum, create some vacuum before you enter the anterior chamber so that you don't catch the iris or posterior capsule. And anterior lip of the cortical fibers is always caught. And once you finish the aspiration, the anterior chamber is filled with viscoelastics, and next is IOL implantation. A rigid PMMA IOL is better, but before you go to learn phaco emulsification, you can learn using foldable IOL, how to load foldable IOL in the injector under the microscope, and then inject IOL, foldable IOL injection implantation. And then the viscoelastics from the anterior chamber is washed out well with the Simcoe cannula. Conjunctival peritomy is cauterized with um, and viscoelastic is washed well. Then you cauterize with wet field cautery, and subconjunctival injection of antibiotics and steroid is given. Thank you. So as we were talking, before you go for phacoemulsification training, make sure that you learn to do good tunnel, rexis in all cases, hydrodissection, as well as in the back placement of IOL. Thank you.
Thank you, Dr. Preeti. Thank you, Dr. Preeti. That was a very comprehensive, and you've covered all the major steps. And now our next speaker for the day is Dr. Jyoti Anup. She is the CEO and Medical Director of Eye Vision Hospitals, Parvatani at Thrissur. Over to you, Dr. Jyoti.
Thank you, Marin. About Dr. Preeti's presentation, SICs also should be done in step by step. The first 5 cases, this is what we do. The first 5 cases, rectus, peritomy, cautery and scleral groove is done. Subsequent next cases, till scleral dissection is done. The next 5 cases, capsulotomy and hydro procedures and nucleus prolapse. And finally, the nucleus delivery, cortex aspiration and IOL implantation. So by the end of 20 cases, the trainee will be able to do the case independently but with supervision. The training surgeon has to be physically present at least in the same OT or in the next OT, so that whenever there is a need for help, they should come and help. They have to bypass that step. So having learned to do good SICs, next step is to upgrade to phaco. So my topic for today is stepping stone to phaco. Why do we need to upgrade? Because the results of phacoemulsification are definitely better than SICs, and very small incisions are possible. We can do under topical anesthesia, and you have the confidence that you are offering the latest technology to your patient. And before starting phaco in your clinic, you have to make some plans and changes. The most important plan is to invest on a phaco machine and a microscope with XY coupling and motorized foot pedal. And besides your own training, you need to train your OT staff also to handle the machine. And these are the technical differences. When you shift from SICs to phaco, there are few steps which are common to both technique, and there are few steps which are totally different. I would like to stress that in SICs, the rexis should be at least 6 mm, and it can vary depending on the hardness of the cataract, whereas in phaco it is 5 to 5.5 mm, and all the maneuvers we have to do it within the capsule. And your training in phaco starts right from when you are doing your SICs. As I told, few steps like tunnel construction, rexis and hydrodissection are common to both, and you have to master all these steps while doing your SICs. And a good hydrodissection is mandatory for phaco, as you need to rotate your nucleus, and no compromise on rexis is allowed, or it is not forgiving. And you can practice your bimanual IA before even starting your phaco, as you can see in this video. And I would recommend this book for all aspiring phaco surgeons to read. And you should have some idea about your phaco machine and the various modes used. In pulse mode, that is the commonly used mode, there is a burst and a rest phase, and this comprises of a duty cycle. And you can set your duty cycle in the machine. Next, another one is a hyperpulse mode. It is better to go for a machine with hyperpulse mode, where the pulses are so short that hardly any heat is produced. And before starting scrubbing, you should go into the OT, adjust your chair, microscope and foot pedals. I am telling you, sitting on a chair with wheels with all 4 your limbs are engaged and doing a tough surgery is no fun. You have to have some time to do it. And after the optimal rexis, this point I wanted to stress, you have to decompress your chamber slightly to do a good hydrodissection. Observe for the fluid wave. And if your hydrodissection is not good, you won't be able to rotate. You can rotate the nucleus 2-3 times before even starting. And this is the technique for a beginner phaco surgeon: divide and conquer. where you have to sculpt and make 2 trenches. You have to go deep, widen the trench as you go deep. You should not push the nucleus while trenching, and make 2 trenches, one perpendicular to each other, to make a cruciate groove. Till this you are doing in a phaco machine setting 1 with a less vacuum. And to crack, you have to keep your probe at the base of the trench so that you get a very good crack. And for emulsifying the nucleus, you have to increase your vacuum. There is a different setting in the phaco machine for that. And for a beginner phaco surgeon, it is better to inject visco before emulsifying each piece, as you may invariably you will be liberating some phaco energy, and that can spoil your cornea. So it is better to inject liberal viscoelastic, especially before emulsifying the last piece. And once you are comfortable with your divide and conquer, you have to shift to the chopping technique. Here I am demonstrating a horizontal chop, where you have to go till the equator and chop. So it is better like you are going nearer the sonule. Some compromise on the sonules are expected, so be ready for that. And in between, when you shift from divide and conquer, you can do a stop and chop. All those things Dr. Marin will be showing you in videos in detail. And after the nuclear emulsification, the trainee should go back to their familiar steps, like you can use a Simcoe in cortex aspiration. So if your hydrodissection is very good, your cortex aspiration is going to be very smooth. You will hardly have any cortex to aspirate. What point I wanted to stress is that the novice surgeon should take only the stress of nuclear emulsification. Rest steps they can do whatever steps they are familiar with. As phaco is less forgiving and every step is important and need to be perfect in phaco. As you can see here, the tunnel was slightly posterior and there is conjunctival ballooning, and this can go up to 360 degree and make lot of stress to a beginning surgeon. And if your tunnel is slightly longer, that will create corneal folds and it will be impossible for you to continue the phaco. And in spite of doing everything perfect, still you can end up in some unexpected problems in phaco. Till the probe is inside your eye, you have to be very careful and vigilant. As you can see, a very small bit of nucleus which should have removed with an irrigation aspiration probe, and a PCR is made. Don't be panic, and you shouldn't remove the phaco probe. As soon as you create a rent, you should inject visco through the side port, and then only you should remove. And always keep your phaco probe in the center of the pupillary area and do maneuvers. If you go in the periphery, you may either catch your iris or the capsular bag, as you can see here. Phaco is less forgiving. You have to be very vigilant and careful. Finally, I want you to drive home the point that how much you're confident you are in doing your phaco, you may still have to convert to SICS. As this is a case of post-vitrectomized eye, you can see the silicone oil in the chamber. So, in post-vitrectomized eye, some posterior capsular compromise is expected. So, anticipating that and planning for a scleral tunnel. So, in case if you have to convert, you can convert it with ease and comfort. And the rhexis was uneventful. And whenever you see a clear area in the phaco, you should always suspect a PCR. And this is not vitreous, this is silicone oil which is coming up. there was a large PC dehiscence. The conversion was already, like, it was very smooth. Or in the other way, when you experience any unexpected problem in phaco, as you can see a large rexis tear known as Argentinian flag sign, don't hesitate to convert. Here it was a clear corneal temporal tunnel, now going for a superior tunnel with a frown incision, and the surgery is completed. So while creating the tunnel, there will be a side port there. You have to go slightly deeper in that area. And go for a 3-piece lens whenever there is a rexis compromise, as you have to implant in the sulcus, and a -1 IOL power is adjusted so that still you may get a metropia. So this is the difference between a planned conversion and an unplanned one. You may still have to suture. Don't hesitate to suture. So this is where the initial steps, the good suture practice is also needed for a sutureless surgeon. Thank you. So the final topic. So the final topic of the session is on entering the world of phaco. We have Dr. Marin Paul, senior phaco surgeon from Thrissur, to guide us in this topic. Welcome, Dr. Marin.
Hello, everyone, and it's lovely to be here. And thank you, Dr. Jyoti, for having me here. So, most of the steps of how to convert and move on to phaco has already been discussed. So I will be talking to you about the core problem in phaco, that is the nucleus management. So what is essentially phaco, how is it different from all the other surgeries, is how you manage the nucleus, right? So there are some prerequisites that you require when you are really going in for a phaco emulsification, and as a beginner, couple of things you should be careful about. So number one thing is that your chamber should be stable. That will of course depend on how well you have constructed your wound, and you should have mastery over phacodynamics. An intact rexis, as Dr. Jyoti said, is mandatory, and your nucleus should be mobile. So for that, you need to also be a master of good cortical cleaving hydrodissection. And last but not the least, good hand-eye coordination, which has been covered in the first talk. So let me talk to you a little bit more about the mobile nucleus. So you should be good not only with hydrodissection, hydrodelineation, you should know all the nuances of small aliquot hydro procedures. And once you've done a good hydro, you make sure that your nucleus is exposed. When you talk about nucleus, it is not just everything that you see in front of you. You have to remove the superficial cortex and the epinucleus, and then you expose the nucleus, and then you start managing the nucleus per se. So what are the basic principles? So basically what you're trying to do here is to remove, imagine a cake tin which is filled with cake, and you want to remove it into small segments, and without crumbling the entire thing, you want to remove it without damaging the container. So that's essentially what you're doing in phaco as well. So what you do is create segments and remove the segments, and what differs is how you create the segments. So we can do it either like in the beginning, we say like always start with divide and conquer, because it is much more safer and much more easier to start off in the beginning. It has 2 steps basically, which is trenching and cracking, and then you move on to the next step of the next level, that is top and chop, and then finally like the so-called the master's technique is the primary chop. Chopping basically can be either horizontal or vertical. Now let's talk a little bit about trenching. So in conventional divide and conquer, we have two long cruciate trenches, and the problem with that is that while you go down and then you go further in, and as a beginner, you tend to forget that the eye, the lens is like it's a prolate thing, right? So what happens is that when you go down and then you should actually go up, but because you're starting off, you forget that, and then what happens is that you can get into a punch through PCR. So another problem is that the hardest part of the nucleus is in the center of the nucleus, and once you finish that and you're still going trenching, you are actually entering into the softer part of the nucleus, and that comes off much faster than you would imagine it would. And again, there is a risk of PCR. So these are the things where you need to be a little careful. So a safer modification to this is 4 proximal short trenches, and so the advantage is that you're always on the downslope and you're parallel to the posterior capsule, which I'll show you shortly. And if you're always in the proximal part, it's very difficult to go and engage the PC. So you can so this is the basic trenching technique, which I said, with 4 proximal small trenches. So you don't go beyond, you don't make that long trench. This is best for beginners. Takes more time, definitely. And so you see, you make that trench each time right up to the center, stop there, rotate, go ahead and make the other trench again. So the length of the trench should always be smaller than the texas, approximately about 5 millimeters. The depth should be about 2 to 3 phaco tips. You should be able to just visualize the phaco, the red glow, and watch for the lens fiber orientation at the floor of the trench. And the width, depending on the hardness of the cataract. If it is soft, please make very narrow trenches, and if it is hard, you can remove more of the nucleus from the center, and this gives you a little more space to work with. Now, second thing is the cracking. Now, when you come to cracking, you have 2 instruments, the phaco instrument, and there is a second instrument. You can use your instrument of choice. You can either go in through the main port and use the side port, and the phaco will actually stabilize your nucleus while the second instrument is doing the separation. And the phaco also helps you to keep the field of view clear. And this is a easier transition when you are trying to move into a crack and chop technique. So there's another technique where you can actually use 2 side ports and use 2 choppers, and you can either use a Sinsky or a chopper or a cyclodialysis spatula, whatever works for you. So that's also another technique, but then you won't get the advantage that I just talked about of having the phaco probe with you. So the cracking technique basically is that, like I said, your trench should be ideal for the hardness of the nucleus. Now, you always position the instrument deep and distal within the trench that you made, and the forces should be parallel to the equator and the bag, and also to the posterior capsule. So your eye should not be bending down. The eye should be looking straight at the microscope. You can make 2 types of separation, either a straight separation like this or a cross action like this. Now, avoid creating a saucer. This is so very common when you're dealing with these softer cataracts. So what you do is maintain those ledges. When does it become this saucer? When you are rotating or when you are trying to crack, right? So keep your instruments in the ledge, so that will help prevent. It's not always possible. If the saucer forms, try to move on to a chip and flip. What you do is that you can make small chips and flip the nucleus prolapse it into the anterior chamber, and then aspirate. Now, this is stop and chop. Instead of divide and conquer, you are having 4 quadrants. In stop and chop, you have a proximal downslope, rotate it 180 degrees, and then complete 1 long trench. And then you crack it into 2 hemi-segments. And once that hemi-segment is made, then instead of trenching further, chop it. So that is it's a transition step to a primary chop technique. Now, coming to chopping principle, you always utilize the natural fault lines, and the phaco tip should always be embedded in the center of the nucleus. That is not just in the XY axis, but also in the Z axis as well. So the two types. The easier one is the horizontal chop, but for that you need a really widely dilated pupil, and the nucleus should be of moderate to hard density. You can use a blunt chopper with the inside cutting edge, and the chopper is passed to the equator, and you beneath the anterior capsule, and you draw it to the phaco tip, and then you, once it is there at the phaco tip, you horizontally separate. Now, for the final or the so-called, the best technique is the vertical chop. Why it is best? Because this is the time. This is the technique which utilizes the minimum time. So you are in and out very quickly. So in this, what you do is you utilize a sharp tip chopper, which you bring it vertically down. Once you embed it into the, the flesh of the nucleus, you embed it, and then you bring the sharp tip chopper vertically down towards the phaco tip, and then pull laterally just before reaching the tip, and this will crack the nucleus. But very important thing here is that you embed it at the appropriate depth. The phaco tip is more exposed when you are trying to do a primary chop, and the chop has to be repeated many times. So what are the things you need to be careful when you chop? You please don't chop the bag, so avoid zonular damage. And once you have, if you try to chop on the bag, the zonules there will get disturbed. There can be Rexis and of course the most dreaded, the PCR. So coming to segment removal, always remove the smallest piece first. Create and remove one segment at a time, and always keep your phaco probe at the tip at the safe zone, right? So these are my parameters. You can have yours, but always bring the segments to the center of the capsule and emulsify it as far as possible in the center of the at least at the pupillary plane. Don't come forward or go into the bag as well. So when you come to the last piece, you need to be a little more careful. Please lower your parameters, both the vacuum and the AFR, raise the bottle height so that your PC is down, and you can actually, the last piece, come a little more further away from the posterior capsule and come closer to the tunnel, but not obviously at the endothelium. And always use your second instrument as a goalkeeper. Sometimes you have this, which is like you've chopped and everything is chopping, but the central hard part becomes one knob, and this is usually in where the cataract is hard. So you can chop the superficial endonucleus like the petals of a flower, and just remove that hard central knob separately, and then proceed with your phaco as you would do normally. So this is basically a kind of pyramid as to how you should proceed with your training. Start with divide and conquer, move on to stop and chop, and then finally the primary chop. But then there may be times when you need to come back down this pyramid as well, depending on the case that you're handling. And there is never, this is the only way I'll do. You always have to keep all the techniques, like Dr. Jyoti said, even at points where you may have to convert. So all the techniques that you can learn them well, and practice and enjoy your entering the world of phaco. Thank you.
Thank you, Marin. Thank you, Marin. That was a real good talk. Now the panel is open for discussion. If you have any doubts.
I would like to ask Dr. Niloufar. You have mentioned a very interesting, all the VR, see that is the future now of the, the training. But actually what is also available in India is something called as Fidelis from Alcon. That is also now being offered. So both Help Me See and Fidelis, I think, are now available. Do you have any experience with any of this? Has anyone here tried these VR trainings, this thing for cataract? No? I am very happy and proud to say that KSOS was the first society across India to institute VR surgical training for KSOS members. We had this session once at Thrissur, and if you get the opportunity, please do go and attend the Help Me See training. It is extremely useful for your cataract surgical trainings. What else? Anything else? Thank you. Okay, time. Any other questions? No. But Jyoti, there was some you did definitely mention that SICS is a great technique, but phaco is the better this thing. I think in the long term, actually, between phaco and SICS, the differences are really narrowing. And yes, immediately there is a big difference, but between SICS and phaco. But now I think the world is actually, a lot of people are looking at SICS as a primary modality for cataract surgery. And what is your opinion on that?
Thing is that actually finally at the end of the day patient will never ask you which technique did you do, why I didn't get vision. So your primary aim, even if while learning you shouldn't spoil the eye, you should always have a concern about the patient's eye and then learn. And that is what I showed actually.
Yes, that is very important.
With that we come to the end of the session. Thank you. Hope it was useful.